Hey everybody, Pupil's Cat. In a grid down situation, you might need a brain surgeon, you might not have one. It's going to be a bit of a problem. Somebody's fallen, somebody's been hit, a tree's fallen on somebody, and you're concerned about their neurological state, their brain. I'm not going to talk about spinal cord injuries, etc. That's far too complicated for a quick video. One of the things you should have is an ordinary flashlight. You really should have one. If you can, get hold of one of these. This is a complimentary gift to find organs from dead people. And it has pictures of the pupil on, big to small. What you're going to look for initially is a whole bunch of things I'm getting to in a minute. But one of the things you're going to do is assess the level of consciousness, and then you're going to reassess that frequently, and you're hoping that it will stay the same and then increase. It may slightly drop. If it drops continually, you're in a big problem. You may be having blood in the brain, somewhere in the brain. In truth, there's not a lot of what you can do about that. There are things that you can do, but mostly you've probably got a person going to die in grid down. So how do you assess pupil response? Well, you get a light and you shine a light into one side. Pupil should constrict. Consensual response, this pupil should also constrict. Okay, so this time look at this pupil and you should see this pupil respond the same as this. So it should briskly respond both sides by constriction, getting smaller. If the pupils don't respond, or if the pupils get bigger, or if this pupil responds normally when I shine the light, but this one ignores it, you might have a genetic thing. But if you've had a head injury, you're going to suspect there's an internal head injury problem going on. So one of the things that you will do is you're now going to assess their motor function, their ability to move. Hey, so what you want to do is you want to Google, whichever search engine you like, something called the Glasgow Coma scale. It's used and has been used for decades. It came from Glasgow in the United Kingdom, and it's a quick method of assessing whether a person is mildly or severely or dreadfully brain injured. The numbers themselves give you a score. The score doesn't really mean a heck of a lot, but the actual areas that are affected do mean a lot. So the best score you can have is 15. So everybody watching this video, including myself, should have a Glasgow Coma scale of 15. And you would use this in addition, you'd use this with the pupil response. And it comprises three things: motor response, verbal response, and eye-opening response. Now for motor response, you want the best limb response, but you would know if there's a difference between the two limbs. So motor response is, if I walk up to you and say, show me your left thumb, that would score 6. If I walked up and said, show me your left thumb, and you didn't move at all or respond in any way, I would assume that you have no response. However, I'm going to inflict pain to see if that's the case. With verbal response, I expect them to be alert and orientated. I want to find out if they're confused but coherent. So what that means is, if you say, how you doing, you feeling okay, and say, yeah, I'm fine, great. Say, okay, you know what day it is, and say, yeah, it's Thursday, it's November, blah, 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 everything's great. And then always ask them place as well. Place, person and time. Say, oh, who am I? And if they say, you're Santa Claus, they're coherent but confused. Or they might get your name wrong, or they may not know what place they're on. The best example I had of this was a patient who was fine, except he was convinced he was on a cruise ship. they would score 4 on the verbal scale. If they're just mumbling words and phrases and you can make out most of them, they would score 3. If they're just going it's a 2. No sounds is a 1. So you probably guessed by now, Glasgow Coma scale 15, you're absolutely fine. But keep an eye on it, because epidural bleeds can take 2 days or so to appear. If they have a Glasgow Coma scale of 3, it means they're not talking, moving or responding in any way whatsoever to anything. Eye opening. If their eyes are open spontaneously, it's a 4. If their eyes do not open to any painful stimulus, it's a 1. So there's no actual 0 on the scale. So the scale is 3 to 15. Now what does the numbers mean? If you score 13 to 15, you might actually still have a head injury. So you could be perfectly fine on 15, but you actually have a mild concussion, so you have to keep an eye on it. You can have moderate disability and you'd score 9 to 12. It's pretty tight, these parameters. A score of 3 to 8 means your person's in serious trouble, so you have to do full dependent care on them and hope they get better. Whether you want to drill a hole in their head, like they used to do in the Stone Age or not, I'm not going to even go there. If you feel you can and you've got the skills and you've read up on it and you feel there's nothing else to be offered, maybe. So that's basically it. So we also look at disability. So when you've had a head injury, you might be unconscious for a few seconds. That's okay, you should be alright, but again, watch out for the next 48 hours or so to 72 hours for bleeding. But you might have a moderate disability. Now a moderate disability, strangely enough, you can actually be unconscious for more than 30 minutes and then revive. That would classify as moderate disability. And those guys probably are going to have some form of memory or physical impairment or both. And you're probably going to need to do some sort of rehabilitation. And rehabilitation in the SHTF is going to be difficult, but it is not impossible. People who are 3 to 8 are basically vegetables. From our angle, in an SHTF, there's not a lot we're going to be able to do for them. Most people with a Glasgow Coma scale of 3 probably will not be actually able to breathe very well unassisted. And there's probably not a lot you can do for them. Right, so that's that, and I hope you enjoyed it. And just to say, briskly constricts, consensual response is fine. Briskly constricts, consensual response is fine. Okay, hope that helps a little bit. Have fun. Bye. Hey, Oops Cat. To assess pain in a head injured patient, if they're conscious, it's fairly straightforward. If they're not conscious or not cooperative, it's hard to figure it out. Like, are they actually going to react to doing stuff? Now, one of the common things you see in the ICU is a patient's in a coma and the family grabs their hand and they squeeze briefly. And the family goes, they're conscious! Well, they're not. It's actually a stimulation that's quite common in deep mental unconsciousness, that if you put anything in the hand will react, and also if you touch the base of the foot, the toes will do this. It's common. To actually assess whether they're baying or not, because they may not be able to verbalise, talk or open their eyes or move their limbs, you ask them to squeeze my finger and let go. Because the let go means they have command. Now one of the other things is for motor response. So number 6 is show me your left thumb, show me your right thumb. No problem. Arms and legs moving, normal function, no problems that you can see. The other one is localizing the pain. So you have a patient that's not really that awake and you inflict pain on them. We'll get into that in a minute. For example, one of the best ways is the supraorbital notch. Now everybody has eyes, and if you actually run your finger across your eye around about here, you will feel the bone go in and then out again, a little divot. Now if you press into that with not a lot of force, don't press the eye, press up into the notch. It causes a lot of pain. Now localizing the pain would be a Glasgow Coma scale of 5. So I'd do this and the patient might slightly have a delay, would go like this, would try and get to the area of pain because they're trying deep unconscious to get rid of it. The other one is withdrawal from pain. So if I did this, they might go and move their limb away from it. Now this is where it gets a little complicated. They're also going to have a flexion or an extension injury. Extension is worse than flexion. So if I do this, they might go like this. So they're flexing up into it, and I'll put some pictures up. Worst case would be a 2, and I do this, and they will extend away from the area, or just extend generally. And in really severe head injuries, you can go like this, and they'll go like that. Not great. If there's no response at all, they're in deep trouble. So yeah, hopefully this helps a little bit. Put some slides in, pictures in with this. Have a little look at this stuff. You don't need to be a brain surgeon in shtf, but it is a good idea for all outdoor activities, for most workers in most manual jobs, and for pretty much anybody that's in a car, to have an idea of how to do a quick neurological assessment and how to do that on a regular basis, so you can chart the progress of the patient and hopefully notice that they're not deteriorating. Alright, thanks a lot. Au revoir.